Marika, morning. How
Good
is
morning.
everybody this wonderful Monday morning?
Just peachy.
Just peachy. Is it cold?
It is low 40s right now.
Okay. I mean, not horrible, but that's still pretty cool. All right, so exam two is done. We're getting ready to gear up for exam three. If you have, if you've not read the announcements, if you were below a 78, please reach out to me with some times and days that you are available to meet, so we can review the concepts for exam two. Moving forward, for exam three, and of course for HESI, at the end of the term. So, and then, of course, keep working on your assignments, your quizzes, all of that good stuff. Get everything turned in on time. How's everybody doing with their group projects? Everybody's been in touch with their groups. Yes.
I have a
Okay.
quick question. So, are we doing like a PowerPoint
Yep.
just
You can just do a PowerPoint.
discussing what you assigned us?
Correct.
Okay.
Yep. We'll just do a PowerPoint on whatever the topic was for your group. And then just remember that each person needs to, when you do the presentation at the end of the term, just make sure that everybody has a part in that, so that everybody participates. All right, so we have two chapters today. We're going to talk about healthcare systems, or I'm sorry, healthcare settings. Um, got my words confused, and then healthcare systems. So we'll go ahead and get started, geez, with chapter 15 in your Success in Practical Nursing book. So, excuse me, I've been sick for like a week, and so I'm at the tail end of it, but it's still kind of not. All right, so I will share my screen. Just give me 1 second. I'm just trying to make this table a little bit bigger for you guys to see. Hopefully that works. Um, So again, chapter 15 is healthcare settings. All right, so the different types of healthcare settings that are out there. And so I will share my screen so that you can see the PowerPoints. I know you guys have them. And my mouse is just acting funny. I apologize for that. Okay. Um, So healthcare settings, not all of our healthcare settings are the same. There's a variety of different funding out there, different types of hospitals. They differ in size, focus, the quality of service, and like I said, and how they are financed. And so when we look at public versus private healthcare agencies. And so they can, this is basically who owns the agency. So they can be owned by the government, they can be owned by private entities, and then that will include both your profit and your nonprofit entities. So here are the major differences on this chart is the major differences between your public and your private healthcare agencies. Um, so here, we have our public official government, and then our unofficial or non-official, and then we have our private. So I'm going to I'll start with public. All right, so there's two types of public healthcare agencies, official and voluntary. Okay, so that's where these terms come from. Your official and your voluntary. Official government healthcare agencies, they are supported by tax money. They're accountable to the taxpayers as well as the government. Their primary emphasis is on the delivery of disease prevention and wellness promotion programs, and they provide direct healthcare services. Your voluntary healthcare agencies, these are supported by voluntary contributions, fees for service, and this is often based off of the patient's ability to pay. They're generally aligned with public opinion, but are accountable to their supporters. Their activities are determined by supporter interest, so they're not legally mandated. And then emphasis on these is usually on education and research. They may offer some direct health services to the benefit to their clients as well. And some official, some voluntary, they're at local, state, federal, and even some of them are at international levels. And then your private organizations, they have fees for service. So you go to, excuse me, you go to go to use their services. There's obviously going to be a fee. Um, their primary surface is disease and illness. They also will provide some disease prevention as well as wellness promotion. Their accountability is going to be the owners, especially with those private organizations. And their programs are determined by the goals of the organization. So, examples of your public healthcare agencies. Oops, I already talked about that. Um, I'll go through there. So at the local level, we have our public healthcare agencies. These are official government agencies. And so this is usually your city or your county health department. They're funded by local tax money, as well as any subsidies from the state or federal government. They carry out the state laws, which are mandated, concerning community health. They also carry out some non-mandated programs like health promotion programs. And then in collaboration with other government agencies, they'll respond to community health issues. So if there's an outbreak of salmonella, an outbreak of chickenpox, measles, whatever, right, they may respond. So again, this is at the local level, that's your health department. Some people have interacted with the health department, others have not. Um, some depending on where you're living and the size of your health department. They may have, STI clinics, they may have vaccine clinics. So way back when, long time ago, during my bachelor's program in Virginia, I spent a week at the health department, um, in various, just as doing my clinical rotation. So I'd spent like one day at the STI clinic. I spent in the STI and the vaccine clinic, and then I spent a day with the diabetic. There used to be a diabetic educator, and she would go out and actually do home visits to, some of the newly diagnosed diabetics, as well as some of the more brittle diabetics out in the community. And then they have something when we look at collaboration here, when we look at diseases or outbreaks. There was another program, it was called the Medical Reserve Corps. And the Medical Reserve Corps served a variety of functions. So, for example, on the Tidewater area, Virginia. I'll just use hurricanes is a big one. Okay, so for example, during hurricane, um, the what do you call it? The volunteers for the Medical Reserve Corps, they would man things like the shelters, right? So if they opened a shelter at a high school, then there would be Medical Reserve Corps staff or volunteers, I should say, to man those shelters, just to assist. What else? There were things like they would arrange for free or low cost veterinarian visits, or not really visits, but they would have like a fair. And so you could bring your animals to do like their vaccines or free checkups, things like that. And then, of course, if there was, another type of natural disaster, in the basement, they had their emergency supplies. So they had food, they had water, blankets, first aid supplies. So part of our bachelor's program was to volunteer to be with the MRC. And so there was a variety of other things too, like for example, part of what I did as a volunteer, I went to some of the senior apartment complexes. And I did blood pressure checks, and I would review their glucose logs when they would, write down their blood sugars, just to make sure everything was going okay. So if they can't handle it at the community level, right, then they may have to ask, or at the local level, they may have to ask for like state or federal people to come in and assist, depending on the disease that was, or the issue that was going on. I also spent a day with the epidemiologist. That was actually pretty cool. And so she told me some of the things that were going on. And this was a long time ago. So apparently, like a really long time ago, but um she was telling me about how there was like a salmonella outbreak one time at a wedding, and so they had to do a whole investigation. So I thought that was pretty cool. At the state level, each state also has its own health department, that's funded by state money, and sometimes may receive money from the federal government as well. And then the federal level. The official health agency at the federal level, that's the U.S. Department of Health and Human Services. It is funded by federal taxes, and has a person appointed by the President of the United States as the head of the agency. And that person will, advise the President of health matters. It has 11 operating divisions, including 8 agencies in the U.S. Public Health Services. And so some of those agencies are like your U.S. Food and Drug Administration, or the FDA, right? They're the ones that ensure all our food, right? All our human and animal medications, our biological products, our medical devices, electronic products that emit radiation are safe, and if applicable, effective, like medical devices, things, even like your artificial joints, um, your, internal defibrillators, your pacemakers, right? Any of those types of products. What else? Your Centers for Disease Control and Prevention, or the CDC. They provide leadership in health prevention and promotion programs. They also respond to public health emergencies. Um, so the CDC, there's lots of resources on CDC, things like your vaccine schedules. If you want to, let's say you decide that you want to go travel out of the country, and you need to know if there's any, additional vaccinations or other preventive treatment that you need to have prior to going to whatever country you want to go to. You can go to the CDC and they'll provide guidelines. The National Institute of Health, they are the ones that fund the biomedical research, in its own labs, as well as in universities, hospitals, private research institutions, as well as the private industry. They train new researchers, they promote collecting and sharing of medical knowledge, and there are 27 institutes and centers, and that will include the National Institute of Nursing Research as well. And there's other ones that fall under your agencies, things like your Agency for Healthcare Research and Quality is another big one. Um, the Centers for Medicare and Medicaid Services would also fall under there. Other ones, you have your American Cancer Society, your American Diabetes, or these are, I'm sorry, these are voluntary agencies, sorry, non-official agencies. So like your American Cancer Society, the American Diabetes Association, American Heart Association, Alcoholics Anonymous, La Leche League, trying to think of other ones. Narcotics Anonymous would fall under here. The American Stroke Association, right? Those would all fall under voluntary or non-official healthcare agencies. Then we brew into our private healthcare agencies. And so they um, they can be for profit or nonprofit, so proprietary or non-proprietary. They do often charge fee for services. Um, They focus on curing disease and illness. A lot of emphasis now, as we know, is on disease prevention and wellness. And these are the ones that you're probably most familiar with that you may use because most people get their healthcare, through these private providers. Um, so under private providers, we have our primary care, right? So that may be your primary care provider, the doctor that you go to for your wellness exams, your immunizations when you get sick. They deliver the primary care. And then if you need to go to a specialist like an orthopedist or an endocrinologist, a neurologist, cardiologist, whatever, they will refer to those specialists. Um, Private practice nurses are advanced practice nurses who counsel individuals on healthcare issues. So these could be like your nurse practitioners. They also, in our rural areas where physicians are somewhat difficult to obtain, they also may practice in those areas. And like for most places too, you go to a doctor's office, they may have one or two actual, doctors or MDs. And then a lot of their rest of their staff are going to be like nurse practitioners. All right, so more types of hospitals. Um, and so lots of hospitals in the area. Depending on where you live, you may have multiple options to choose from. In some areas, there, may be fewer options to choose from as far as where to go when you need an actual, hospital type care. Um, so we have community hospitals, we have the government hospitals, and we have non-federal psychiatric hospitals. Um, so community hospitals um, provide a pretty wide range of medical services. Sometimes, though, with community hospitals, they may not have the specialists to treat serious conditions, or, other unusual conditions. And so they may have to, if you have something really serious, you may have to be transferred to a different hospital. Um, your specialty hospitals are a little bit different. They offer services related to a particular disease or condition. So things like your trauma centers, your ENT, your rehab hospitals, orthopedics. Sometimes, you may find the specialty hospitals are actually part of another type of like a bigger or a bigger hospital. Like, I'm trying to think of an example. Um, like a hospital that has just a general inpatient hospital, they may have a specialty hospital that's attached to it, that does like acute rehab or intense rehab. Um, but they're generally, obviously, with the specialty hospitals, those providers are specialists. They have advanced knowledge, working in those areas. Your voluntary or your voluntary community hospitals, these are associated with your community associations or religious organizations. So I'm trying to think of like Shriners Hospital or St. Jude's Children's Hospital would be an example of those. They provide short patient, inpatient care for those that have acute illnesses or injuries. They are heavily dependent on gifts and donations to supplement their revenue, right? So you always see especially around like the holidays, even more so, but periodically through the year, you'll see like the St. Jude's will have their telethons. Like up in Virginia, they would have a CHKD, will have theirs as well. And with the voluntary community hospitals, the Board of Trustee appoints a paid administrator that will manage the hospital. Your state or I'm sorry, your federal or state government hospitals or your public hospitals. These also include things like the Veterans Administration, the state, county, or other, more municipally owned and operated nonprofit hospitals. We also have the hospitals for people that have serious mental illness that are also operated by federal, state, or county funds. The teaching and research hospitals, both community and federal government hospitals can be teaching and research hospitals. They have a variety of goals. They treat clients, especially those that have serious or unusual conditions. They're training sites for healthcare providers, nurses, and other health professionals. And they work on research and developing treatments for disease conditions, health promotion, I'm trying to think what else, as well as ways to deliver, low cost, high quality care. They are almost always affiliated with medical schools. So you have pretty high access to really skilled practitioners. I'm trying to think of like, Harvard Medical Center, Boston University Medical Center, Vanderbilt, right? Again, most of these are all, affiliated with medical schools. You do have other training hospitals like, the Veterans Administration hospitals, some of your other military hospitals, even though they're not associated with medical schools, they often will have providers that they're being trained. Your critical access hospitals, these generally they provide specific Medicare conditions, and so they usually don't have any more than 25 inpatient beds, with an annual average length of stay is no more than 96 hours for acute inpatient. Um, and then they're more in rural areas, at least 35 miles drive away from any other hospital. They can care for common conditions as well as outpatient care. But then, in severe emergencies, they'll stabilize, right? And then have to send them to a larger healthcare system, right? 25 inpatient beds, right? They only have an average stay of 96 hours. Some of those more urgent cases are going to be sent to another hospital. So lots of different types of hospitals and just understanding if you go back to this chart at the beginning, oops, this gives you just like I said, it's just a breakdown of, each type of those hospital settings, where their support, their services, their accountability, and how they determine their programs. And we'll go back. Um, so as I went through, can you guys identify in your areas those different types of hospitals? I know Virginia pretty well, right? It's I only spent 30 years there, but like They have lots of military hospitals. They have a big, huge military hospital in Portsmouth. They have the Veterans Administration in Hampton. Centera is a big hospital group, which is for profit. Riverside is another one, right? And there's a couple smaller hospitals in the area as well that are not part of the bigger groups. Um, and so it really just kind of depends. And then downtown in Norfolk, we have Eastern Virginia Medical School, right? And that is on a campus with your Children's Hospital and I think it's Centera Norfolk Gen. So they're all kind of collaborate together. So they also, there's lots of research studies that go on at EVMS. A lot of the training that those, the students that are at EVMS, they go to Norfolk Gen, they go to CHKD to do a lot of their training. So there's lots of interaction amongst those different groups when we go into, outside of the hospital system, right? So, we have things like our ambulatory services, which, those are your outpatient clinics. And there's a variety of different types of outpatient clinics that you may find as well. They provide follow-up care to clients once they get out of the hospital, right? So, you spend time in the hospital and maybe you're a newly diagnosed diabetic, okay, and you not have maybe haven't had any kind of primary care, right? So those outpatient clinics, right, will follow that diabetic person after they got out of the hospital. They can also manage diseases for those that don't need to be hospitalized, right? So newly, have hypertension. You don't have to go into the hospital. They can manage your hypertension right on an outpatient basis. Diabetes can be generally, right, managed on an outpatient basis. So again, they can often, manage diseases for those that don't need to be hospitalized. They can be part of healthcare facilities or they can be freestanding. Um, so it depends again in the area. It also includes your specialty areas, your diabetes, neurology, allergy, oncology, ENT, um, cardiology. I'm sure I'm missing a whole lot, but, again, specialized clinics for, different diseases. And they have, usually are going to have an appointment, right? Most places, if you have like a, primary care provider, you don't just walk into the office in the morning and say, hey, I'm here, I need an appointment, right? You generally have to call in advance, schedule an appointment to go and see the providers. Urgent care centers, these or provide services for walk-in clients. Um, they, for a lot of people, they replace healthcare providers' office. So a lot of people will use these, the urgent care centers as more of a, primary care rather than just an urgent care. Um, the name kind of reflects the type of care they provide. So express care, quick care, urgent care. Trying to think of some of the urgent care center names, and all of a sudden now I can't. Um, think of any. But there's usually a variety. I thought it was really interesting. It was a little bit of a culture shock moving down here. Yes, in Virginia, we had urgent care centers, right? I mean, there were not like abundant, but there were quite a few, right? Coming down here, I would tell you in a mile from my house, there's five within a mile. Like every block, there seems to be an urgent care center. So like if I ever got sick, like I could literally go like half a mile down the road and there's an urgent care center. Um, it's just crazy. I've never seen so many before in my life. Like the little strip malls and stuff, there's an urgent care center. I'm like, okay, random. Um, and I often wonder how they all stay open because every time I drive by, like there's nobody there. There's the sign says it's open, but I don't ever see anybody in there. But I just thought it was really interesting. Another thing that I thought was really interesting down here, which I didn't see in Virginia, what is it? It's not see Walgreens. Is it Walgreens? Yeah, it has to be Walgreens. Uh, is it Walgreens? Wait a minute. Now I think I'm confusing myself. It has to be Walgreens because it's not CVS. There's actually providers' offices in Walgreens down here. And I never seen that before. So like it's a regular Walgreens, like you can still go in and buy like, your over the counters and random stuff, but they actually have providers offices in there now. So I thought that was pretty interesting. I'm like, okay. Um, so yeah, it's different. I had never seen that before. I don't know if that's like the new way that Walgreens is going. But I thought that was pretty interesting too. We have 1 day surgical centers or ambulatory surgery centers. And so, um, you know, if you don't have to be hospitalized overnight for, your procedure, then you may use you may go to an ambulatory surgery center. Um, these are not complex surgeries. Okay. So you need to have a heart valve repaired or, open a cabbage or, some kind of other complex surgery. You're not going to go to an ambulatory surgery center. Okay. These are, surgeries that, they can come in, usually don't have a whole lot of issues and they can go home, right, without any kind of serious, you know, concerns. I'm trying to think of sometimes even your, hips and joints, depending on the procedure. But again, it's not a complex surgery. These are simple procedures that can be done. I'm trying to think of, so my daughter, she had her tonsils taken out in an ambulatory care center. All right, so we went in, she got her tonsils removed. We took her home right at the end of the procedure. Um, so again, usually not complex surgery. Um, it can be within a hospital as well. So if you go to a hospital, you may see two different types of surgeries. You may see outpatient surgery and inpatient surgery, right? Outpatient surgery, you're going to go in, you're going to have your procedure. At the end of your procedure, you're going to go home. With inpatient surgery, right? You're going to have your procedure and then you're going to a unit, right? You're going to either stay overnight or maybe a day or two, depending on what the procedure is before you go home. So you can see the 1 day surgery centers in a hospital or freestanding. It just depends on how it is set up. We have some communities will have free clinics or reduced clinics as another way of providing primary health care for, these generally will provide for people who can't afford traditional health services. Um, the cost is often based on income. They usually will have an income limit or age limit as well. There's usually like a salaried administrator and then volunteer healthcare providers and nurses. Um, and then they have a volunteer board that, makes policy decisions for the clinics. Um, depending on your area, you may have one free clinic or you may have multiple free clinics. It really just depends. Again, most of these are volunteer, providers that are staffing those clinics. And then when we get into your um, alternatives, so we have community-based care. So you have like your skilled nursing care, things like your long-term care facilities. help people who have disabilities or chronic medical needs. Um, Skilled care is what we is care that is medically necessary to improve the quality of the client's health or maintain or slow decompensation of a client's condition. And so in order to, have skill, in order to have skilled nursing care, you have to have a skilled need. Um, so when we look at that, oh, it's not there. Uh, some of the examples of skilled nursing care, um, injectable medications, IV medications, ostomy care, certain wound care, oxygen, respiratory care, would be considered um, skilled nursing care, sometimes care provided after somebody has had a stroke. Um, Getting a diabetic stabilized would also be considered, skilled care, physical therapy, occupational therapy, um, respiratory therapy, speech therapy, trying to think of what else. Nutrition therapy, like if somebody had like a G tube or a PEG tube, would require, skilled services. And so, of course, a lot of education is providing to get them to be able to take care of themselves or even to train um, family members or caregivers. Home health services. Home health services, this is care that is provided to the client at home. In order to receive home health services, the person must be considered homebound and they have to have a skilled need. And so the purpose here is to promote, maintain, or restore health, or minimize the effects of illness or disability. And a big part of your role or the role of a home health nurse is education, right? So we're trying to teach the client and the family self-care. Usually the RN is going to be the case manager. Um, and so skilled services can be your skilled nursing care, your PT, your OT, your speech, home health aid services as well. What's the difference between a home health aide and a CNA? Anybody know?
Are certified through the state.
Okay. Anybody know what a home health aide does?
Home health aide just goes in and provides services like cleaning, running errands, companionship, versus a CNA does like a little bit more complex as far as like helping with ADLs, doing grooming care, um, incontinence care, transferring. Some home health aides are not allowed to use like mechanical lifts and things of that nature.
Right. So when I was a home health aide, we didn't do any of that. So literally, we do vital signs. We may help to transfer. We also may, would do like you said, some light cleaning, some cooking, even assisting with some like you said, some small transfers, right? We're not going to use any kind of lifts or anything like that, but we could help them to get out of bed, things like that, help them get dressed. Yeah, so it was a, I started off as a home health aide a long time ago, but so yeah, so different types of, services, whereas your CNAs will come in and do the bathing and the ADL care, the incontinent care, that kind of thing. But like cooking, like cleaning, yeah, that kind of thing. Um, They offer, they may offer home health, may also offer, even respiratory care, the nutrition care, sometimes even podiatry, having, podiatrists come in as well. It really just depends on, the home health services that are needed. Your skilled nursing services, those are going to be provided or directed by the RN. Um, and then the basic nursing services would be provided by LPNs. And so, what I'm trying to think of, injections, your glucose testing, um, teaching, creating the safe environment. And then, of course, the treatments like your wound care, your ostomy care, bowel and bladder retraining. So, variety of different services. Again, in order to qualify for home health services, they need to be considered homebound and they have to have a skilled care. So, again, here are some of those basic skilled nursing services that can be provided in a patient's home. IV medications, right? So, depending on the situation, they can receive IV medications at home as well. So, I had osteomyelitis. And so rather than go to a skilled facility, I, had a PICC line inserted and my IV medications were sent to my house. The first day they came in, they showed me how to use my IV pump. It was really cool. It was really tiny. It was in a little fanny pack, so I could wear my little IV pump. Um, I had 24-hour antibiotics. So my bag had to be changed. I want to say it was like every 6 hours. And so when they first came in, they of course, did their assessment. They showed me how to set up my pump. They showed me how to change out the medication bag, which, I was a nurse, but it's always nice. Um, and then the best thing that she did was put an extension on my pick line because the way the pick line was, I couldn't reach it to try to use two hands to try to connect my bags. So she put an extension on there. And then after that first day of training or first day of, the assessment and education or whatever, then they would come out once a week. And they would, draw labs and change the dressing on my pick line site. And I had it for 8 weeks. I had my pick line. So lots of different services that are provided. Didn't have they didn't come out every day. Like I said, after that initial day, it was once a week, just for the dressing change and the blood draw. And then when it was time to have it removed, of course, the nurse came out and she was able to pull the pick line. Other types of care, we have community health nursing services as well. And so the major focus of community health is improve the health status of communities or groups of people through education, screening for early detection of disease, and provide services for people who need care outside of the acute care setting. Adult daycare centers. Adult daycare, these are actually really cool. So these are services for clients who need supervision because of physical or safety needs, but are not candidates for nursing homes. Okay. So generally with your adult daycares, the client lives with a family member or other members of the family, family or friends or whatever. And those, they get assistance in the evening hours and on weekends, but they don't have the assistance during the day. All right. And so literally is a daycare center. So they, when we look at, some of our older people who, not only for socialization needs, but for safety needs. They can go in the morning, they can get their socialization, they may also get assistance with some of their ADLs. They're in a safe environment, right? They are observed. So typically with your adult daycare centers, they will offer transportation, they'll offer meals, activities. There's nursing there. In some cases, too, they may also get some rehabilitative services. And so they're actually really nice little centers. Um, there's, usually a social worker or an RN that's an overall supervisor, and then they have like CNAs or personal care assistants to assist with the ADLs. They also may have some volunteers. And then even, depending on the size, they may have some, LPNs and others that work there as well. But again, it's for people that live with family members and have the assistance in the evenings and the weekends, but just need somewhere to go during the day. And think about it, if, especially with some of our dementia patients, right, who may be a safety, maybe a safety risk for them to stay home by themselves during the day, right? They get the supervision, they get the socialization that they need, and then, they still have the care when they go home. Independent living facilities, um, these are not licensed, they're not regulated, but they're just independent living, apartments. They don't get any personal or medical care, but they're basically just living with people of their own age, right? So think of like your senior living apartments. Um, Assisted living, these provide home with services. And so, has anybody ever seen an assisted living facility? They're really nice. Some of them are really, really nice. They're, for older people that are trained, they want to live independently, but they may need a little bit of help with their ADLs. And so they usually have their own little like type apartment, right? Or with their own rooms, their own bathrooms. They're usually, they're going to be handicapped accessible. And so there is, help that they will get with daily routine. Some employ 24-hour CNAs, others do not. It really does depend. It's not 24-hour care as necessarily, but they can get help with bathing and dressing, health management. So they will have like case management and skilled nurses when needed. Um, so like, and I've seen assisted livings. It depends. Some assisted livings are like attached to long-term care facilities. So like one side may be assisted living, right? And then should something happen, like they need, they fall, they break a hip or, have a stroke or heart attack or, some other, issue, then they can go to the uh, the long-term care side, get their skilled nursing services that they need, right? And then they can either transition back into the assisted care side or they can transition to long-term care, depending on the seriousness of the disease and the services that they were prior. But assisted living they're really nice. Your um, residential care homes. So residential care homes are things like your group homes, family type homes. They can provide either temporary or long-term residential care. Um, and so this is those with mild cognitive or even mobility issues. They're usually overseen by, I think it's Social Department of Social Services, I think oversees the care homes, your, and then your continuing care retirement community. These are actually pretty cool as well. And so they provide a continuum. So they may have independent living, assisted living, and long-term and skilled care all on one campus. Okay. Um, so you may have like independent living apartments, right? Something happens and you need to transition. Maybe you need more of assisted living, right? And then you can, move to that part of the campus. And then again, if something happens, then you can go to the skilled or the long-term care side. So it's all within one area and it provides, different levels of care. Um, so, it's, convenient, right? Not only, and it's not a huge amount of change for the person as, things happen. So I will tell you though, some of the independent and assisted living facilities are super expensive. Um, I don't know how some people afford them. I will tell you. Just for example, before my mom passed, we were trying to look at some different options and she had mentioned assisted living. And so I'm like, okay, so she had looked into some options. One of them was like, and this was 10 years ago. Um, it was like $4,000 a month for just the apartment. And they only provided 2 meals a day, right? So whether it was like breakfast or lunch and dinner, or whichever one, and then any activities. So like, if she wanted to like take the bus to go shopping, whatever it was, were additional fees. So I was like, it was really, really expensive. And of course, I think she probably picked the biggest, nicest one that she could find too, to kind of use that as a but I was just really surprised at the cost of some of the facilities. Um, Other ones that I've seen are a little bit less expensive, um, but provide some basic care. So it really just depends on the needs. A lot of your older people too, they realize they're getting older. They can't really take care of their house anymore like they wanted to, right? These are some really good options for them. Because don't have to worry about going outside and mowing the lawn, right? Or what to do when the AC breaks down, or I need a plumber, right? These, provide the basic services, just like if you were renting an apartment. Um, and then your rehab services. So rehab services, right? They function on, they look to get return of function and prevention of further disability. Basically, the goal is to try to get them as close to their previous level of functioning as possible. Um, and so rehab services, they can, take place in rehab centers, your skilled nursing facilities, long-term care facilities, outpatient, residential homes. Again, home health care is an option as well. And of course, we know nurses play a huge role in that. Um, so skilled nursing facilities, right? You have skilled licensed personnel, so RNs and LPNs. You also will have, your PT, your OT, your speech therapy. Vital signs are monitored, medications, wound care, right? Whatever other skilled nursing care that needs to be provided. Um, excuse me, as well as, the personal care that is needed as well for those clients. Oh my goodness. Sorry, my computer is doing something silly over here. I don't know what. There it is. Okay. And we have wellness centers. So wellness centers promote wellness and detect disease in early stages. Not all hospitals, have programs to, detect disease in early stages, but that's why we have these wellness centers. So they may offer nutritional counseling, exercise programs, stress reduction, weight control. Um, Things are like your weight reduction programs would be things like Weight Watchers. They may also offer like classes on smoking cessation, parenting classes. Um, I'm trying to think. That's and then hospice care. So hospice is end of life care. And so they are available in many areas. That they have been diagnosed with a terminal illness. Generally speaking, it's 6 months or less to live, if the disease runs its normal course. Okay, so if you have a terminal disease and less than 6 months to live, then you're eligible for hospice care. Does that mean that you have to die within 6 months? Absolutely not. I've seen residents be on hospice for, years and still receive hospice services. Um, the philosophy of hospice is to maintain comfort as death approaches, right? It's death with dignity, is the biggest. Um, it can be, and we can provide, I mean, hospice care can be provided anywhere. I mean, you can get hospice care in the hospital, you can get it in long-term care, you can get it at home. Some people also, there are some places actually have hospice houses or hospice homes, that they provide care for hospice patients. Um, yeah. Um, and so, there's hospice care, they have RNs, LPNs, home health aides, CNAs, there's also volunteers, social workers, pastoral care services. So a variety of services that are offered through hospice care. And, if you want to die in their own home, right? That is an option for them. So even though my mom looked at all those wonderful assisted living facilities, when it did come time for us to put her in hospice care, her desire was to die at home. And so we, of course, kept her at home, and we had hospice services that would come into the home. I think it was, a couple times a week. And then, of course, if we needed the nurse for any other reason, we could just call the nurse and the nurse would come. So it really kind of, the level of services is different. I want to tell you one of the biggest things that, been a nurse for a long time. I've worked with a lot of different people. Um, Most of the hospice patients that I've worked for, that um they've all been DNRs. Coming down here, I actually have hospice patients that are full codes. And I haven't quite figured out the dynamic yet. I just thought it was interesting, that, when you look at the premise of hospice, right? Comfort as death approaches, death with dignity, right? The focus is, right? To have hospice patients that are full codes was a totally new concept for me to understand. But yes, I guess they can still remain full codes. Another thing that I found that was interesting, just based off the state, um, when I was used to hospice care, once the patient was in hospice, right, the care was directed by the hospice team, right? And so down here, and they only may be hospice for one of their diagnoses, but then all of the other care for other management of, their chronic diseases is done by their primary provider, where hospice only manages the one disease. And I just thought it was just such an interesting, I don't know, it's just an interesting, though, what's the word I'm looking for? Um, Dynamic, I guess, right? That you have everything is being managed by one provider except for whatever their hospice diagnosis is. So it's interesting how when you go from one area to the next, right, that you get to see how, different things are done in different areas. And then we have palliative care. So palliative care does provide comfort care similar to hospice, but we use palliative care at the onset, of treatment, and it can be accessed at any stage of illness whether the client is terminal or not. Um, and so it's most often we're going to have a team of professionals. While receiving palliative care, they may still choose to receive life-saving implementation or intervention. So let's say they have a cancer diagnosis, um, and they're still receiving chemo, right, and radiation. So they're still, receiving life-saving services, right? But they're also getting the palliative care maybe to treat, right, the side effects of the medication or the side effects, as a result of the diagnosis. Not all palliative care is hospice, okay? But hospice does, we do provide palliative care in hospice. So it's just a little bit different level of care. So again, anybody can get palliative care. I mean, palliative care can, in its simplest form, is like giving IV fluids to somebody who is severely dehydrated, right? That's a palliative care service, right? It's designed to try to help them feel better, right? But they're not terminal because they're dehydrated, right? So that's like an example of a palliative care service. So I see some people need to use the restroom, and that's fine. Let's go ahead and take a break and be back at 10:10. All right, so just finishing up with palliative care again. So palliative care improves the quality of life of patients and their families by relieving symptoms and stress of a serious or debilitating illness, right? So loss of appetite, pain, nausea, sleeplessness, help with healthcare decision making and supporting family members, right? So again, palliative care is often used with hospice services, but you can receive palliative care without receiving hospice. Um, so just a recap, lots of information in these slides for you, but we look at, healthcare services. We can deliver those in both private as well as public settings. Public healthcare agencies are either official or voluntary. Your official healthcare agencies are supported by taxes. The official public health, our local, state, as well as federal agencies. The official agency at the federal level is our Department of Health and Human Services. Um, Public Healthcare Agency of the United Nations, which is your international, it's your World Healthcare Organization, or your WHO, which is your World Healthcare Organization. Voluntary health agencies are supported by contributions. Trying to think of what else. Um, your primary care, right? That's where usually most of us get our initial health services, right? That's um, your primary care provider. Specialty hospitals, usually treat specific diseases or specific healthcare needs. Teaching and research hospitals offer treatment for serious or unusual conditions, usually are a training site for healthcare professionals. Um, your free clinics provide primary care for patients who can't afford traditional healthcare services. They're usually income based. They may also have age cutoffs as well. Um, Trying to think of what else. So again, lots of different types of agencies that are available to provide healthcare within your community. And depending on the community and the size of the community too is going to depend on what services are available. Um, so not every area may have every type of healthcare entity. Um, but the bigger the area, generally the more access you have to certain healthcare. Chapter 16, right? Chapter 16 is healthcare financing, or financing the issues and the trends. So this is basically how, healthcare services are paid for. Um, So, go into the hospital, you go to the doctor, and how is your care, right? How is it paid for? So I will share. So, nice little statement here. U.S. healthcare system has been described as poorly organized and complicated maze of services, which lacks preventative care, waste resources, and is very expensive. And I'm sure those of you that have had to use healthcare understand that it can be very expensive. Um, so historically, how did we get to the point that we were at back in the early 1960s? The provider, they had a fee for service payment model, right? So, we went to, or prior to the 1960s, sorry, probably, you go to the doctor and they charged, you just had to pay the fee for whatever the cost of the healthcare services was. And so that can definitely, increase prices as well as, there wasn't a whole lot of cost containment. And then in the 1960s, We had the Medicare changes. Um, the Medicare changed from fee for service to what we call prospective payment, based on DRGs or your diagnosis related groups. And then other um, insurances follows. So basically, what that means is so to help fight the cost of the cost of healthcare. Um, Basically, what the diagnosis related group is. Let's say, um, I'm just gonna use, let's say you go to get your yearly physical at your doctor's office, okay? And so, maybe they were gonna charge you, $500 to get your physical, okay? With the DRG, um, it was, if you have a client that's coming in to get their physical, maybe the DRG is that, group is like, okay, it's 300, this is $300, to go get your physical. All right. And so that would be whatever the reimbursement is. Okay. So same thing. And other insurances kind of followed that. And that was one of the ways that they decided to cut costs. It's the same thing when you go into the hospital. Let's say you get admitted because, we have a client that had a heart attack. Okay. The prospective payment system and the DRGs, they're going to say this is the flat rate for somebody that's had a heart attack based off of, whatever the diagnosis is. All right. And so the hospital is going to get reimbursed that fee. All right. And so they made an agreement with the insurance companies that they are going to accept that flat rate for whatever the diagnosis is. So that was like I said, that was one of the ways that they can try to cut costs. So the hospitals are reimbursed again based off of that DRG. And so what does that mean? That means that there is more of um, a focus too on minimizing length of stay as well as minimizing extraneous tests and procedures, right, to kind of cut the costs as well. Um, and so this payment system goes to all healthcare provider payment, which led to managed care organizations. Managed care organizations are things like, if you have ever had to look at, and choose um, you get a new job, and you've had to choose what's it called, health insurance plan, right? This could be, you have the choice, some, HMOs, PPOs, point of service plans, right? So usually like you'll have a couple different options when you go and you sign up for benefits, right? And you have to look through the benefits to see which one's going to be better for you. Um, so that's that. So despite all the changes, we still know that there was a significant amount of healthcare costs. There's, increased costs. There's also inequalities in healthcare access, right? Not everybody had access to healthcare, particularly the unemployed or uninsured. And so generally speaking, the poor generally also would have trouble accessing healthcare. So lots of things as a result. And think about it, right? What happens if you may not have insurance, right? And what happens when you get sick or you have to go to the doctor? Um, then you end up in the emergency room or at the hospital, right? And then, if you don't have insurance, then you're going to be required to cover the costs for that care, right? And then what happens then? If you don't have the money, right, you're not going to pay the healthcare services. And so the hospital is then going to increase their prices to cover for the loss, right? So it ends up being a very vicious cycle. So then we had in 2010, right, we had the Affordable Care Act. that was signed by President Obama. Um, and so it was the, first wide sweeping piece of legislation to address healthcare reform since 1965 when we had when Medicare was added to the Social Security Act. It was designed to enhance access and affordability of healthcare, especially, to those in financial need in the United States. Um, and so it did decrease the number of uninsured in the United States. We still have plenty of people that are not insured in the United States, but it did decrease the amount of those. Um, what else? It also established a health insurance marketplace. And I don't know if anybody has ever looked at the marketplace before, but the marketplace is a resource where either you as an individual or a family, even small businesses learn about their different options that are available. Um, so you can go on there and see what, options you have for, finding a plan, as well as enrolling in coverage. It also provides information on programs that help people with low to moderate income, and resources to pay for coverage. Um, so it did, like I said, did help. It also allowed states to determine Medicaid eligibility requirements. When we look at Medicaid, Medicaid is state funded. And so every state has their own specific Medicaid eligibility requirements. But the Affordable Care Act did do a lot for a lot of people, as far as getting healthcare services. And it still does. Um, so again, that marketplace is available. Some people have been able to get coverage that wouldn't have been able to have gotten coverage prior to. So when we look at financing, the two most common ways to finance healthcare services are what we call fee for service and capitation. So fee for service is the traditional way, right, that we pay. Healthcare providers are paid a fee for each service that they provide. They are directly reimbursed for most diagnostic tests and treatments for illness. Some insurance companies do not um, reimburse for preventative or diagnostic tests for early stage disease. So we know that that's still always going to be an issue. Capitation, um, healthcare providers receive a fee per member over a designated time frame. So again, it's a set monthly fee that's charged by the provider for each member of the insurance group for a specific set of services. For healthcare costs that cost more than the monthly fee, the provider absorbs the cost, but the goal is to keep the members healthy. So if you think about that, right, it's kind of like your car, and think of your car insurance, okay? Pay your car insurance every month, right? Most people don't need their car insurance, right? Um, do you, or even like your homeowner's insurance, right? Or your renter's insurance, right? You pay those fees every month, and it goes to the company. And like I said, you may never even use your car insurance, your homeowner's insurance, or your renter's insurance, whatever, but you're still paying for it. Other people may be using it, right? But then when it comes down to it, then, you have that, whatever, if there's somebody hit your car or something happens, right? You have that insurance to help offset the cost of repair. It's kind of very similar with capitation. That provider is getting this set fee for you every month, but what happens if you don't go to the doctor every month, right? They're still getting that fee. So when it says that the provider absorbs the cost, a lot of times it's not really even absorbing the cost because if you don't use the services, right, that's still money in their pocket. So how do we pay for healthcare services? Uh, so personal payment, right? That was the primary way of paying right before all of the healthcare acts started to become an issue, become into play. So, back in, my grandparents' time, again, go to the doctor and if you were sick and doctor said, okay, it's $20 for this, then you just paid the $20. Um, and so now, that same $20 physical would be like $2,000, right? And not everybody has $2,000. So we generally don't use this system anymore. Um, Most people, have, tried to get some sort of insurance. Um, Although I had a friend, bless her heart, she had private business and did not have insurance. So it was a really small private business. I mean, she only has like 10 employees, so it's not a huge business. Um, Never had health insurance as, either, for her employees or for herself. And then kids happen, right? Kids get hurt, kids get sick. And so she, after, her daughter broke her arm, had to have surgery, like crazy healthcare costs, she decided to, get away from that personal payment, right? And get a health insurance plan that would be beneficial for not only her family, but for her business as well, right? So those out-of-pocket costs, and even with insurance, so I'm not going to lie, some of your out-of-pocket costs can be very expensive. So we have private health insurance. And so private health insurance pools individual contributions for a common group goal. Right? It's offered by most employers in the United States. So again, you go to get you get your first nursing job or you start a job. There is usually going to be some sort of a health insurance plan that is going to be offered by your place of employment. Um, the Affordable Care Act does impose penalties for larger employees that don't provide insurance. So most places are going to provide insurance. The cost of your insurance, that is also determined by your organization. Okay, so how much you have to pay. But examples are like Blue Cross and Blue Shield, United Healthcare, Aetna, Cigna, right? These are all examples of private group health insurance. Your private individual health insurance, these are offered by insurance companies to those that are not part of a group. Premiums for your private individual health insurance are based on your health risks and your age, as well as like things like tobacco use and other things. So look at health insurance terms. And these, as you're moving forward or even trying to explain it to other people, are things that you need to understand, especially when, if you've never had to pick an insurance before. So premium, that's the monthly fee a person may pay for that you must pay for your healthcare insurance. Okay. So you go to work at the hospital, right? When you graduate from school. And they're going to give you the options that you have for health insurance. The first thing you want to look at is the premium. How much are they going to take out of your paycheck every month or every 2 weeks for your health insurance? Your premium is usually offset by your organization as well. So depending on where you work, they may offer, they may pay, they'll pay a percentage of your premium. Again, it really just kind of depends on where you're working. So always look at your premium. Your deductible is the yearly amount that you must spend out of pocket for healthcare costs before your health insurance policy will begin to pay its share. So again, this is something that you want to look at. Good. You may see, oh, my premium's only $50 a month. That's really good. I can afford that. But if your deductible is $10,000 a year, then that $50 a month really isn't going to be a good benefit for you. Okay. So you have to look at your deductible. If you have, it's yourself, your spouse, or if it's yourself and just your kids, you really want to look at the deductible. How much time do my kids spend at the doctor? If I'm going to the doctor often, or, the kids are going to the doctor often, then, you may meet that deductible very early in the year, and then the rest of it will be free. Really just depends. A lot of times, too, when you look at that, both the premium and the deductible, it's going to be different for individual versus a family. All right, so look at those two numbers. Your copay, that is how much you have to pay when you go to the doctor's office, or when you have to pick up a prescription, or even hospital services. So copayment, I'm just going to throw out general numbers, okay? None of these probably accurate anymore, but let's say it's $25 to go to the doctor. Okay, that would be your copay. Um, your prescription, right? That's going to be different depending on what medication it is, right? It could be anywhere from zero to, $1,000, whatever it is. Hospital services, those are also dependent too. Like an emergency room visit, it's going to cost more than an urgent care visit, so you have to look at all of those different costs. Then your co-insurance, once you've met your deductible. So let's say you have a $3,000 deductible, you've met your deductible, there's still the co-insurance. All right. And so those, once your deductible is met, that's the percentage of the bill that you have to pay. All right. So there's still going to be, no matter what, there's still going to be out-of-pocket costs. So, when you're really looking at choosing an insurance plan, really understand what those costs are and how it's going to affect you moving forward. Because, even with insurance, again, there's still going to be out-of-pocket costs.
Quick question. How would you spend the deductible?
So your deductible, so let's say, um, you go to the doctor, and you paid your copay, but you haven't met your deductible. Basically, you're going to pay that visit. You're going to have to pay that visit out of pocket until you meet your deductible. So for example, I'll use myself as an example. All right. So my husband and I are both vets. Okay. So in Virginia, I'm not gonna lie. The the veterans using my VA services in Virginia was absolutely horrible experience, because the VA hospital, you could never get an appointment. Okay, so we moved down here. I have a disability, so I have to see the VA for certain things. Okay, uh, the VA hospital down here, I have all of my care at the VA hospital. So I don't have, whatever I have, my wealth, my physicals, my disability stuff, all that stuff is covered. So I haven't been to a private provider. So with that, we haven't paid anything. So we haven't met our deductible for the year. So my child gets sick, my son gets sick, and he goes to the doctor. I thought he thought he had strep throat. And so he goes to the doctor, and we get a bill in the mail for like $300. And I'm like, why are we getting a bill? We have insurance. Well, because my husband and I aren't doing our annual, or, every 6 month lab work and, visits and stuff. We never met our deductible. So now we're paying out of pocket for him to go to the doctor because we haven't met our deductible. So that's kind of where that is. So that's why it's important to look at your deductible, because like if you're someone like my son doesn't ever get sick, I think, it was like the first time that he went to the doctor, in 2 years. So they'll look at that deductible, because if you don't go to the doctor very often, then you're not going to ever meet like we'll never meet our deductible because we're not using the services. So like I said, it's really important when you're choosing your health insurance plan that you're looking at all of those numbers, because they do add up.
I just have another
Um,
question.
Go ahead.
When you talk about meeting your deductible and you say it's like 5,000, you kind of have to pay out of pocket until you hit that 10,000 mark, correct? Or $5,000 mark.
Yeah. Yep. Yep. And it's usually not that much. I'm just throwing numbers out there. Um, I want to say like because I want to say for ours, it's like, I think we have like, I think for our family plan, it's like a $2,000 deductible. Um, But like I said, we usually meet that pretty easy because we were all using the same doctor, right? We were doing our well checks and our blood work and all that stuff. And so we were meeting that usually early on. But now that we're not using it like we're not meeting our deductible. So, yeah, so it's just interesting. So he'll eventually get his own job, his own insurance and stuff, and it'll be different. But for now, it's not. It's just not effective. It's not working for us, So, but again, like I said, when you go to get that job, make sure you look at all those numbers. It's nice to have a low premium, but if your others or numbers are really, really high, then you kind of have to see how you're using the services. Public health insurance. With public health insurance, this is your Medicare, your Medicaid, and your veterans health insurance. So I'm going to do veterans first. Um, is it even here? No, we'll just go back. So veterans health insurance or veterans health plans, there we go. They're the Veterans Health Administration. This is comprehensive health services for all veterans. And so there's hospitals, there's outpatient clinics, there's even nursing homes for veterans. I noticed in Virginia, they just built a whole new VA center where I think in Chesapeake, I was reading an article, which I think is absolutely crazy, that they built this brand new facility and they haven't been able to staff it fully.
Yeah, they're like 200, I think, something of available positions still open. And they only
Right?
been
I'm
open
like,
for like a few, not even a year, and there's still a ton of positions still open.
yeah. And it's surprising because, a lot of people want to go work for the VA. I mean, the benefits are good, especially if you want to go back to school. That is something that you may want to think about with the VA, because they will help you to, pay for you to go back to school. They have some really great benefits at the VA. Even if you decide that you want to train, you want to move, you can always try to transfer within the VA system. But yeah, that was very surprising when I saw that article. I was like, why are there some, it makes you wonder why all those open positions are there. I didn't look to see the list of positions, like I didn't look to see what was available, but I just thought that was really interesting.
I tried to also, I didn't see any LPNs. I went to the VA website for that, and I didn't see anything for
Oh,
LPN wise. I think it's mostly RNs from
really?
what I've seen.
Are you looking at USA Jobs?
Hmm.
Okay.
And VA careers, I think also.
VA careers. Interesting. Huh. I wonder. But yeah, that's a lot of jobs to still have open, right? After, still being open and still having that many positions available. So Medicare. So in 1965, Medicare was added to the Social Security Act. It is a federally sponsored entitlement program and public health insurance plan. It helps to finance healthcare for all persons over the age of 65 and their spouses who have at least a 10-year record in Medicare covered employment and are a citizen or permanent resident of the United States. So what does that mean? That means that you had to have a job that pays into Medicare for at least 10 years. Doesn't have to be 10 consecutive years. All right. It has to be 10 years where you have paid into Medicare. Then when you turn 65, then you are eligible for Medicare. Um, no person is denied coverage based on past medical history. All right. So you have a pre-existing condition or, something, maybe you had cancer and, whatever. You cannot be denied coverage based on your past medical history. Um, so there's lots. Um, Medicare is, pretty extensive healthcare options. There's lots of different moving parts within Medicare. So it's, when we look at this, so we have Part A. Medicare Part A is your hospital insurance. Okay, so it covers your inpatient hospital stays. If you have to go into a skilled nursing facility, hospice care, it also will pay for some home health care. Part B is your medical insurance. So that will cover certain healthcare provider services, outpatient care, medical supplies, preventive services, your diagnostic tests. Trying to think of what else. Um, B also covers mental health services, ambulance transportation, some diabetic supplies. It also may cover PT, OT, speech therapy, um, again, some preventative services as well. Part B does not cover your prescriptions, dentures, dental care, foot care, hearing aids, eye exams, and glasses, none of that. Part C is what we call the Medicare Advantage plans. These, you especially I think on it's starting in like November. I just remember seeing all the commercials and hearing it on the radio. When we look at, open enrollment for Medicare, I think is in like the first part of December. So you'll start hearing all these commercials for these Advantage plans. They're offered by private companies that contract with Medicare. These can be your HMOs, your PPOs, your fee-for-service plans. Um, they offer, this will offer sometimes to your prescription drug coverage as well. And then you have Part D, which is the prescription drug coverage. So the Medicare drug legislation that was passed in 2003 provided prescription drug coverage to help pay for brand name medications at participating pharmacies. Um, and this one is also offered by insurance companies and other private Medicare companies. Um, so Part A, your traditional Medicare is covered. All of the additional ones are additional out-of-pocket costs. All right, so have to be really careful with some of these because they're going to be additional out-of-pocket costs. So when we look at Medicare supplemental, because there's lots of things that Medicare does not cover. All right. So a lot of people are encouraged to get these supplemental insurances. The supplemental insurances can help you pay for the copays, the deductibles, the co-insurance, that kind of things. And so, we look at, you're entitled to Medicare, you meet the requirements for that, but there's still going to be plenty out-of-pocket costs. Um, so like for myself is an example, okay? When I get to 65, we have TRICARE. All right. So my husband's retired military. Um, and so once we hit 65, he will transition to TRICARE for life, okay? When we are eligible for Medicare. But in order to keep our TRICARE for life, we have to enroll in Medicare Part B. All right. So we have to have both in order to keep our TRICARE for life. And hopefully with that, it'll offset the rest of the other, healthcare costs. I'll have to look into it when I get closer to that age. If Medicare is still available by the time I get to 65, who knows? Um, so again, there is that supplemental coverage that people can get. Clients cannot enroll in both Part C and D. Okay, so if you have a Advantage plan, Part C that includes prescription drugs, then you can't join Part D. And if you join Part D, then you can't be enrolled in Part C. So there's lots of different rules when it comes to Medicare. On the other hand of this is Medicaid, okay? So Medicaid program was added as well to the Social Security Act in 1965. It provides medical assistance for eligible families and individuals with low income and resources. Um, and so the federal government does provide some broad guidelines for Medicaid, but Medicaid generally is established by each state. So each state will give its own services as well as eligibility requirements. All right. So if you have Medicaid in, Virginia, and you move to Pennsylvania, okay, each state determines its own eligibility. So if you are eligible in one state does not necessarily mean that you're going to be eligible for Medicaid in another state. Um, the undocumented immigrants and legal immigrants who have not resided in the U.S. for 5 years are not eligible for Medicaid. Um, let's see. Then we have CHIP. So CHIP is actually a really good program as well. It is the Children's Health Insurance Plan. It is a program under Medicaid that provides medical assistance for eligible children. Um, so it covers uninsured children up to the income guidelines, and free or low cost health insurance for kids up to age 19. And so this is actually a really good program. When I worked in peds, I worked with a lot of families that had CHIP, and it really does help. It really does help. So cost of health insurance. When we talked about, right, some of the costs that are involved. I'm going to see if I can pull up an example to show you. Um, but as healthcare prices, of course, go up, so do the annual increases in health insurance premiums. So I don't know if anybody, like I said, not everybody has health insurance. See if I can find, um, I was going to see if I can find one that would kind of show you what it would look like. Oh, it's not working for me. Why is this not working? Oh, because I'm not signing in anywhere. But so the Affordable Care Act um does requires the federal government to create a process in conjunction with states where insurance have to justify unreasonably unreasonable premium increases. And I'm trying to remember, I don't know how much the actual price went up to know that if it was pretty significant. But yeah, some of them, could be pretty costly, so you want to be really careful. So one of the biggest things that we do worry about was nurses as healthcare providers, um, is the uninsured. And there's lots of reasons why we worry about the uninsured. For one, generally speaking, they don't have access to insurance. They don't have they generally will not, take place in the health promotion activities like the screenings and things that we worry about. Um, so uninsured could be your low wage employees. So they have low wage jobs that are less likely to offer insurance benefits. It also could be the middle class. So some of the middle class workers are unemployed. Or when you look at some of those premiums, that have to pay for healthcare, that could be a reason why people are not having insurance as well, right? Because if you're making minimum wage and your premium for your insurance is $500 every 2 weeks, you're not going to be able to pay the $500 because you're not going to have any income, right? So we really look at, the uninsured. This is a very vulnerable population when it comes to, healthcare within society. So alternatives that we do have for the uninsured, Medicaid, if they qualify, again, Medicaid is income based. So they can always try to see if they qualify for Medicaid. There's private pay, which we know private pay is extremely expensive. There offers, there may be charity care that is available as well. Um, it used to be, and I don't remember when this changed. Okay, so it's been a long time. But it used to be that, if you didn't have insurance and you didn't pay your medical bills, right, it didn't affect your credit score or anything like that. Now all of that has changed, right? They can report your medical debt, which can affect your credit score. So these patients can face medical bankruptcy. Uh, and like I said, if you don't have health insurance, if you don't have access to health care, then they're not getting the preventative care. And so diseases are found during later stages, which generally speaking, the later stage, right? We know there's a much poorer prognosis, but the cost of healthcare is also going to be more expensive, especially to be treated. So like think of your cancers, right? Cancer, if we find it early and we start treating it, right, generally there's less cost, better outcomes. But if it's found at a later stage, it's going to be a lot of, a lot higher cost, because it's going to require a lot more aggressive care. And additionally, too, they may rely on the emergency departments for all levels of healthcare, right? Because they don't have insurance. So we really have to look. And then who pays it? So who do you think, if I don't have health insurance or I don't have, the money to pay for my emergency room fee, who pays that bill? Who pay? How is that bill paid?
Would they, if they say they'll pay the hospital bill, they just have to like write it off or eat that cost or something like that?
Okay. Then the hospital may eat the cost, and then how do they recoup that money?
Charge, maybe you have to increase to make up, find another way to make it up.
Right? They're going to increase the, oh my gosh. They're going to increase their costs, right? To try to cover or offset the losses that they have, as a result of those that are unable to pay. Another thing we have is called the prospective payment system. And so I touched on this a little bit earlier today. So your prospective payment system, or your PPS is a system of reimbursement that pays a predetermined fixed amount for per patient admission, regardless of the actual cost to provide the care. And this is those diagnosis related groups that I was talking about earlier, the DRG. So payment is, based on a classification system for that service. So, like I said, somebody, comes in and they're having a heart attack and they're admitted to the hospital. All right. So the hospital is aware that, okay, I have a heart attack coming in. This is what my reimbursement is from the insurance company for that heart attack. All right. So the government announces to the hospital what it's going to pay for those costs. All right. So we know for this heart attack patient, we're going to get, $15,000, whatever it is. I don't know what it is. All right. Um, so one of the big things with that is, right, that, it does give the incentive to control their input costs, their resource use. All right. So, when you think about it, going into your patient's room. All right. So, you're working in the hospital and, you've got to go do wound care. Right. I'm just going to use that as an example. Instead of bringing a whole package of 4x4s and, two rolls of tape and all these extra supplies, just bring in what you need, right? Because anything that goes into that patient's room has to stay in that room. You can't bring it out and use it on another patient, right? Uh, so a lot of your cost containment. We did have some issues, and there probably still will be some issues, right? That, we're discharging them too soon. They're, not 100% stable when they're being discharged, which can lead to a reduced quality of care. So there's very fine line, right? We already know how much we're getting reimbursed, and we're going to do our best to stay within that reimbursement, but it's not always going to be 100% possible to do that, right? Because things happen. So this is that DRG. Again, it's another way to try to stop the cost, the high cost of healthcare. And so again, it's just the fee that the companies or the government's going to pay for hospitalization. So again, they already know how much they're going to get depending on what that patient's diagnostic or that diagnosis is. So when we look at DRGs, right? The focus really is on quality of care versus quantity of care, right? So you can go in and out of a patient's room 100 times a day, right? But if you're not providing quality of care and that client is not satisfied with that care, right, then that's going to decrease the quality of care that you're providing. At the same time, all right, so you have that patient that just came in for a heart attack. I don't know, something happened. Maybe they had to have bypass or, some other procedure done. And let's say they're laying in bed and they develop a pressure area. All right. So that's not quality care, right? So who's going to pay for that pressure area now and the longer time that they're in the hospital? Who's going to pay for that? Is the insurance going to pay for that pressure area that the hospital caused by not turning and repositioning or providing other preventative services? No. I see you shaking your heads no. They're absolutely not. They are absolutely not. Okay. The hospital is going to provide for that. Same thing if somebody gets a catheter associated UTI or a central line infection. Or what if the patient falls and breaks the hip on the way to the bathroom? All right. Those are not going to be covered by insurance because it was a preventable, um, illness. Okay. So big, huge focus on quality of care versus quantity of care. All right. So before we get into quality and all of this other wonderful stuff, let's go ahead and take a break. Be back at 11:10. All right. So, talking about quality, safety, and cost of healthcare. So lots of reasons why healthcare costs a lot, right? Prescription medications, obviously the use of new medical technology, right? We continue to make advances in medical technology, right? Something is always newer, bigger, better, improved, which is going to increase the cost of healthcare. We have the highest healthcare spending of all industrial countries, but we also have a lower life expectancy and higher infant and mortality and maternal mortality than many of the other industrialized countries. So we don't, doesn't mean that we are not, providing that quality and safety of healthcare. So the Institute of Medicine was renamed the Health and Medicine Division. It's a program unit of national academies. Um, and so, looking at improving healthcare. So I don't know if anybody has heard of this before, but back in 1999, um, we had a study that was done. Um, by the Institute of Medicine. It was called To Err is Human. And so, again, this was done in 1999. And the report found that up to 98,000 people, a lot of people, die each year from preventable medical errors. Um, and so the one of the things that the study also did was to identify some ways that we could try to prevent some of these medical errors. I don't remember what year was, I don't remember if it was 10 years later or 20 years later. They did a follow-up study um, and found that there was not a significant improvement in the um, in a reduction in, medical errors. So we still had a significant amount of people that were dying or even less severely injured as a result of medical errors. So there's always been a, continuous push to improve quality in healthcare. So one of the things we have is CQI, which is continuous quality improvement. And so with CQI, um, it we look at client incidences of harm or mistakes that after they have occurred. Okay. So let's say you're working in a long-term care facility and you've had patients fall, okay, either with injury or without injury. Okay. The CQI committee is going to go back and they're going to review all those cases of those patients' falls, okay, and then look at ways to prevent them from happening again, or even preventing adverse events. Okay, so CQI looks at things that have already happened to try to improve upon. Um, the aims of the Institute of Medicine for improving quality in healthcare. There are six aims underneath the Institute of Medicine. Um, and so it's STEEP, STEEP, is the acronym. And so it's SAFE, is S. So avoid injuries to clients from care that is intended to help them. T is for timely, so reducing waits, and sometimes harmful delays for both those that are receiving care and who we're giving care to. STE, the first E is effective, sorry. That's providing services based on scientific knowledge. The second E is efficient, avoiding waste of equipment, supplies, energy, that kind of thing. And then the third E is equitable, providing care that does not vary in quality because of personal characteristics. So gender, ethnicity, geographic location, socioeconomic status, and then C is your client centered. So STEEC, STEEC, is providing care that is respectful of and responsive to individual client preferences, needs, values, right? All of those things. Um, Continued competency. This is another big one. This is continuing education as well as certification. So we always need to be able to demonstrate competency in our skills, right, and things that we are doing and providing care for our patients. And so current licensure considers nurses from all levels of education. So think about, you graduate nursing school, you get your nursing license. Does that mean you're never going to learn anything anymore, that you never have to do anything to keep that license? Absolutely not, right? So when you graduate, the school is saying that you have, the minimal competence, and knowledge, that you're minimally competent in your skills and your knowledge in order to practice as, a licensed practical nurse, and you take your NCLEX. Most states have continuing education credits that you must complete prior to licensure renewal. So depending on what state you're in, make sure you go look at your state board of nursing to see what your continuing education requirements are. It is a yearly requirement. Be mindful of that. You can't just, oh my gosh, my license is due next week and I have all these CEs to do. So be mindful that you have to do those every year. A lot of places too will have like what do they call, like skills fairs. Um, like when I worked for CHKD, which is a children's hospital, we had a skills fair every year that we had to go and get signed off on all our skills. Any other organization that I've worked at, there is an annual skills fair that you have to attend to show that you can still perform those skills appropriately and safely. So mindful of that. And then, of course, your, certification, should you choose. So there are some certifications that are available to you as you become an LPN. So if you choose, like the long-term care certifications, one of the new ones, if you choose to get certified. As you go back to school and you get your RN, then there's more certifications that are open to you. Improving safety in healthcare. One of the big ones is the Joint Commission National Patient Safety Goals. If you have not looked at those, I suggest you look at those. The National Patient Safety Goals are listed. They, list them for all areas of healthcare. So you'll see some for long-term care, for hospitals, for ambulatory clinics. There's, it's going to, be different depending on where you are. Nursing, right? We try to promote safety first. And so Joint Commission they go back and they review adverse incidents, where there's been serious harm, and death to clients. And that is how it establishes its national patient safety goals. The National Patient Safety Foundation, um, it also focuses on client safety. So they partner with clients and families, the community, to improve client safety by avoiding errors of omission, commission, or execution. So whether we did something wrong, didn't do something, or did the right thing wrong, whatever. They offer other like things as well. And then we have the transition to practice, and I really like this program. And I wish more organizations instituted this. So the transition to practice was an initiative by the NCSBN, which is your National Council of State Boards of Nursing, to improve the quality and safety of healthcare by improving new grads' transition to work. All right. So, think about it. put you, we get you through school, you take your NCLEX, and then we throw you out into the world of nursing. And depending on where you work is going to depend on the amount of orientation you get. So for example, and one thing that I will tell you, I've worked in long-term care for on and off for my whole career, in varying roles. And the last role that I had, was a corporate educator. And so one of the things that I pushed for and it was able to enact with the company that I was working for was a better orientation process. So we take new grads, all right, brand new grads. Some people have had, experience in healthcare. Others have not had any experience in healthcare. We give them 3 days of orientation and we throw them out onto the unit by themselves. Okay. And so, you know, there, I don't know if any who's you guys have done clinicals in long-term care, right? So you've seen what it's like to push that med cart in long-term care, right? So you may have what 30, 60 patients to pay, mostly like 30, 36 patients to push medications to, right? Depending on the size of your unit. In addition to medications, you have treatments. You also have to monitor patient statuses, right? And deal with everything else, CNAs and families, providers, right? So lots of moving parts, especially if you're on day shift. All right. Evening shift, there aren't as many resources for new grads to go to, right? And then if they work overnights, there's even less resources, right, for a new grad should something happen. Um, so this program, and though it's mostly in hospitals, okay, um, okay. Um, that transition practice model is anywhere between 9 and 12 months. And so again, it's improving safety and quality as the new grads are transitioning into the actual workforce. And helps with a lot of things. I know like a lot of hospitals even include like simulation and other skills practices as part of this program. Uh, so I would like to see it more. Other hospitals, if they don't use the transition or practice from the NCSBN, they have other like, things like residency programs or other programs for new grads in hospitals. Um, Long-term care, like I said, did push to get the orientation process a little bit more, I wouldn't say organized, but a little bit longer, making sure that they have the appropriate resources, ensuring, if something does go wrong, that they do have a resource available to them, so that they don't feel like they're on their own, but, um, so, there's those things. Um, and then for improving the cost of healthcare, um, cost containment, it's always going to be the biggest things. We want to try to keep the cost down as much as possible. And so some of the things that the LPN or your role in containing costs, um, making sure that you're following your policy when it comes to charging clients for supplies used in their care. So like, you may have your Pyxis for medications, but you also may have a Pyxis for supplies that you will charge to, that you may have to charge to the individual room or the individual patients, making sure that you're doing that appropriately, that you're not, if they only need one of something, that you're not pulling two or three and charging them. Making sure that you follow your policies about documenting client care as well. This is a big one. You've all heard if it's not documented, it's not done. So make sure that you document all the care that you provide to that client. Make sure that, you've got good time management skills. Making sure that you're efficient and effective in delivering your care. Again, remember, you can go into that client's room 100 times a day, right? But is that really efficient, right? So making sure that you're using your time efficiently. Making sure that when you do a procedure or something that you do it correctly the first time so that you don't have to repeat the process. Um, make sure that we're meeting the client's needs so that they are satisfied with their care as well. Um, we're the ones that spend the most time with our clients, right? So we want to make sure that we do the best that we can. Other quality improvement measures that we have pay for performance. What is it? Pay for performance, never events, and align payment with client outcomes. Sorry. So pay for performance. Has anybody heard this before? So pay for performance. Oh my gosh, I can't even say it. Pay for performance. It rewards hospitals for meeting um, and exceeding standards of care for a variety of diseases. So in, your diabetes, your heart attacks, your pneumonia, your heart failure. Again, so it's a value-based payment that offers incentives, and it could even offer penalties as well. So this, looks at quality metrics, patient outcomes, efficiency, that kind of thing. And the goal here was to improve the quality of healthcare delivery, um, increasing preventive services, right? Lower readmission rates. Um, and then we have our never events. Never events are the never events are, I can't even say it. Serious and highly preventable events. Um, So, what are some things that would fall under never events? Your hospital acquired infections, so your catheter associated UTIs, um, your central line infections, pressure areas, injuries from a fall, and trying to think of what there's other things that would fall, medication errors, incompatible blood transfusions, um, oh, what is it? Impersonation of a healthcare provider. That's another one. We think of all of those nurses out there that were practicing without actually, with not good licenses or, pretending to be nurses and not being a nurse. That would, also be fall under a never event. With never events, hospitals don't receive any reimbursement. So again, we talked about that. If you have your client comes in, they've had a heart attack, and you get their reimbursement for the heart attack, but while they're in there, they develop a catheter associated UTI or a pressure area. Again, the hospital's not going to get reimbursed for that. Another one too that we look at is readmission rates. If um, discharge someone too early, but anyway, a readmission is when clients are readmitted to an acute care hospital within 30 days of discharge. All right, so diagnoses, acute MI, heart failure, pneumonia, COPD, knee and hip replacements, cabbage. And so the biggest thing here is to improve transitions in care. So let's say, um, have a patient that had, I'm trying to think, let's say they've had a hip replacement. All right. And, generally speaking, they don't stay in the hospital for very long after a hip replacement, right? Um, but maybe they develop an infection at the surgical site and they have to go back into the hospital for, treatment of that infection. So transition of care, of course, we know is a big issue. But we also want to recognize any early complications. So, you're talking to your patient and trying to maybe they're getting ready to discharge and maybe you pick up on some red flags about them going home. All right, making sure that you're bringing that to the attention of the RN, the case manager, right, something along those lines. It's sometimes it's even the care managers or maybe the social workers that are following up with the patients once they get discharged. Excuse me, so we can try to intervene before any complications that can occur. Does it mean that we're never going to have readmissions? Probably not, right? Because we can't always control what happens once they leave the hospital, right? But we're making sure that we're providing the education, giving them the necessary education as well as the knowledge in order to manage their disease processes once they leave the hospital. So the nursing actions for quality improvement. So again, some of the things that we can do, and I'll make this bigger because I cannot see it. Um, so talked about these already, the STEEC or P. So your steep, right? So avoiding injuries to clients, right? Reduce waits and sometimes harmful delays, provide services based on knowledge, avoid waste of equipment, provide care that does not vary in quality, and then patient-centered. Um, there we go. Um, oh my gosh. I made it too big. Now you can see it. Again, we have the National Patient Safety Goals, the National Patient Safety Program, and that transition to practice are some of the things that you want to be familiar with, especially the National Patient Safety Goals. So like for example, I'm trying to think, the national patient safety goals, it's, one of the big ones is always going to be medication safety, right? So using the two client identifiers, give me an example of two client identifiers.
Asking for their date of
Name,
birth and
date of birth.
comparing it to their wristband.
There you go. Asking for their name and date of birth, right? Hospital systems are great. They have the nice little scanners, right? You scan their armband, scan the medication, and automatically goes into the EMR. Think about long-term care settings. One of the nice things about long-term care now, since the introduction of the electronic medical records and things like that, they take pictures of the residents now, so the picture is right there in your EMR, so that you can compare the picture to the person that you are, giving medications to. Because think about it, if you're working with a bunch of dementia patients, they may not always remember the information that you're asking them. So you have that other, patient safety goals. Communication improvement is always going to be one. Medication safety, alarm safety, alarms, alarm fatigue is a real big thing. Um, so never not answering an alarm, whether it's a call bell, a bed alarm, depending on where you're working. Um, infection prevention is always going to be something that you should be very mindful of. Has anybody heard of enhanced barrier what is it? It's EBP, enhanced barrier precautions? So yeah, I got so enhanced barrier precautions. So if somebody has like, I don't know, has a wound or like C. diff or shingles or something, we use contact precautions, right? Or we use enteric precautions if they have C. diff, right? You gown, your glove, you mask, go into your patient's room, right? You have your regular precautions. Enhanced barrier precautions, these we put into place for patients that have IVs, that have Foley's, peg tubes, anything invasive in them. Um, and it's if you're going to go in and you're going to, hook up an IV medication, or you're going to, um, you know, uh, do something with their feeding or do calf care. Um, then you want to still gown and glove. The process with that, the reason behind that is because they have an opening into their body. It's not protecting us, it's protecting them. So that's your enhanced barrier. And you'll see that a lot, especially in long-term care. So like I said, if you're going to provide G-tube care, pulley care, IV line care, whatever it is, you're going to gown and glove. It's not because your client has an infectious process. It's because we're trying to prevent us from giving them something. Trying to think what else. Um, we talked about the transition to practice model. Like I said, I really like that model. Talked about those. So long-term care, national patient safety goals, resident identification. It's always going to be one in long-term care. Um, they may not, we don't generally in long-term care, you're not going to use a scanner. A lot of times in long-term care, they may not have an ID band on as well. They may have started with one, and it might have gotten removed or disappeared. Um, so sometimes identifying, we have to have an effective way of identifying our residents. We're still reducing the risk of healthcare associated infection. That's why I talked about the enhanced barrier, reducing the risk of harm from falls, preventing pressure ulcers. So, what are some ways that we prevent pressure ulcers?
Rotate the patient every 2 hours.
Rotate, turn and reposition every 2 hours. What else can we do?
Making sure you're changing their incontinence pads at a timely manner, not leaving them on
Okay.
them.
Okay.
You could what they call like the heel boots, the Una boots. You can float their heels off of the pillows. Um,
Okay.
like put a pillow, like if they having like a pressure ulcer, just say like on the right side of their buttocks area or in their continence area, probably want to float them, turn them to the side, like Matthew said, turning them every 2 hours or whatnot. Like, put a pillow like up under them, like turning them to the side, getting them off of that pressure area, and applying a barrier, like some type of barrier.
Okay.
Also, maybe if they have any type of wound dressings, check those every now and then, see if they need to be replaced, or if they have any type of surgical scars or any type of rashes. Check on those for their skin integrity every so often.
Okay. Okay, good. Hydration as well, making sure that they stay hydrated, making sure that they're eating, they have good nutrition, right? All good things. What about how do we prevent falls?
Keep the bed at the lowest position and make sure the alarm is set so if they do move around, we would know about it and have their call light near them.
Okay.
And you want to
What,
implement like non-skid socks. Like you want to orientate the patient to use their cow light if they need to go to the restroom, and try to have your aides to toilet them before laying them down. And if they put their call light on, just go see what they need.
okay. Um, so in long-term care, we don't use bed alarms. We don't have bed alarms. So we don't always know when they're getting up out of bed unassisted. So yes, beds in the lowest positions, call bells, um, the non-skid socks, um, dementia patients. I'm gonna be honest with you, a lot of them are not going to use the call bell. The more confused they are, the more likely they are going to get up to try to, do whatever it is that they want to do. And so a lot of it is frequent monitoring, frequent rounding, offering assistance rather waiting for somebody to ask for assistance. So, going in and, do you need to use the restroom or, making sure that they are clean and dry? Because if you're uncomfortable, right, you're going to do things that you would not normally do, right? Um, so yes, good job. Oops. Talked about these. Um, the universal protocol for preventing wrong site, wrong procedure, and wrong person surgery. Has anybody heard of this before? Going into a surgery, they'll do like a timeout process. And they will run through like who the patient is, what surgery that they're doing, that kind of thing. That's another way for us to try to prevent that. Um, you know, it's still scary that it still happens, but making sure that the safety procedures are in place and that people are actually following the safety procedures. Um, Trying to just make sure that I kind of covered all of this. I just want to make sure that we um restructuring of the healthcare system. So with the restructuring of the healthcare system, it's a lot of it is about partnerships. And that's always going to be a big part. When we look at, not all, all hospitals being part of the same system, but partnering, right? They coordinate care delivery. They can also help contain costs. Um, Mergers are always going to happen, where larger systems acquire smaller systems, which, start to see more and more, especially in long-term care. Not that it doesn't happen with hospitals as well. But a lot of your long-term care facilities now, there aren't as many that are independently owned and operated anymore. They're usually a part of some sort of a bigger group, whether it's national or even local areas may have, few. You'll start to see more and more of this. It is cost effective for these organizations because you have a bunch of different facilities under your control. Maybe one facility is a very high earner, right? And one is a lower earner, right? But they kind of helps to offset the costs. So it also helps to standardize care amongst the group. Um, so there's different options. Um, it's just interesting how things have changed so much over the last 30 years. But so what can you guys do? Be self-directed, motivated, be a problem solver. And I know that sounds kind of vague and kind of, I don't know, maybe even scary. Um, but you get to be the nurse that you want to be. Okay. Um, and so remember that you're taking all the information that you're learning in nursing school, you're looking at, you've seen good nurses, I'm sure you've seen not so great nurses, you've had good in nursing instructors, maybe you've not had good some have not been the best, okay? So you can take all of this experience, people that you've worked with, nurses, And you can take your experience and you can shape yourself into the nurse that you want to be. Identify what needs to be done and do it. That's always a big one. Be flexible. Healthcare is ever changing. It's ever changing. And that's one thing that you can guarantee that is going to happen is something is going to change. As soon as you get comfortable doing something one way, it's going to change. Be flexible. I know a lot of people are resistant to change and that, can be a little bit difficult. However, try to be flexible. Usually it's changing for the better. Um, Identify tasks or protocols that could be done more efficiently. If you see a practice, a policy, a procedure, or something where you're working and you think that there's a better way that it can be done, do your research and present that. They're always looking for people that or have input into, procedures, and things that can be um, improved upon. Some places, the people that are writing the procedures aren't the ones working with the clients or working with patients. And so they're not seeing the same things that you're seeing at the patient level. So be mindful of that. And like I said, if you see something that can be improved upon, submit it. And be a role model. And this one to me is is huge. Um, Nurses, we have a lot of responsibility in caring for our clients, in caring for their family members, being responsible, working with doctors and other nurses and your CNAs and administration. And I'm sure I don't know. I don't know because I don't know everywhere everybody has gone. Okay. But I am sure at some point in your school career or your school clinicals, you've had a nurse, maybe one, maybe more, that have been very reluctant to work with students. Anybody have that experience? I'm trying to be politically correct when I say it. Okay. Um, I honestly don't understand that philosophy. I don't understand that way of thinking because there is not a nurse out there, unless, of course, they paid for their schooling and didn't actually attend it, that has not had to do clinicals. Okay. That has not had to, you know, spend 500 hours in a clinical setting during their education. All right. Everybody has had to do it. I had to do it. The nurses before me had to do it. I don't understand why nurses do not want to work with nursing students. They had to start somewhere. And so the only thing that I can say is don't be that nurse. Like, don't be that nurse. Um, And like I said, you've had a variety of experiences throughout your nursing school, good, bad, whatever. And you get to choose what you want to be when you go out and practice. But you remember where you came from. And I know days are rough. Trust me, I know. I work overnights and I see it. And I know what my workload is. Um, Everybody has to learn. And so if you're not willing to teach them, how are they going to learn? And being respectful and being nice and being understanding is always super important to understand. And I know, like I said, I know the workload is crazy and sometimes having a student does slow you down a little bit. But in the long run, it's better because that student that you are working with today may end up working with you tomorrow, right? And do you want to have, how do you want that relationship to be? Do you want it to be a cooperative relationship, right? Where, oh my gosh, you were my nurse when I was in nursing school and you were great and you showed me this, this, and this. Or do you want it to be, oh, you were that nurse that wouldn't help me when I was in nursing school. So now why do you expect me to come and help you now? Right? So you get to determine that relationship. And I know that, like I said, I know that in some of your experiences, it may not have been the best. However, right, we can make it better for the future nurses. I love, well, I know it's going to sound dumb, but I love working with nursing students. Um, whether it's in the classroom or in the clinical. I think it's fun. I love to teach, and I think that's why. And I know that not everybody likes to teach and, and I don't know, but I look at it this way too, as at some point in my, in my life, I've had to have people take care of me. One of the biggest examples that I have is before Fortis, I was at another school in Virginia. Um, and while I was there is when I had my osteomyelitis in my foot. And I had to spend 6 days in the hospital, up in Williamsburg. And I would say, in the 6 days, about the majority of the nurses that were there were my prior grads. Okay. And so at some point in our lives as nursing instructors, we're going to have grads that are going to be there to take care of us. And so how do you want that relationship to be, right? Um, so there's lots of different reasons why I look at it the way I look at it. It's because, you guys are going to be taking care of me, and even the ones that we're training out on the unit, I want to make sure that they're trained good and well and know what they're doing so that if I do ever get sick, at least I can trust the nurse when I open my eyes and I see her standing over me. Um, I don't know, just different experiences. And I, like you, have had that same experience when I was in nursing school, oh, not students again, or I had, been there, just go stand over there. I'll call you when I need you. And you're just literally standing there in the corner, just begging, right, for something to do. Um, Although I will tell you, since I have a couple minutes left, the best experience I had as a nursing student was in my associates. Yeah, my associates program. We were in the ER. Um, and the nurse that I was working with couldn't remember my name. She called me student the whole time, which it was okay. Like that didn't bother me because I tell you what, she dragged me everywhere. Dragged me everywhere. And she was like, "Come on, we're going to do this. Come on, we're going to do that. Come on, we're going to do this." And then as we're doing things, she's actually asking me about like what's my experience? What do I, what do I want to do? Like she didn't just ignore me. To the point where I forget what we were doing, and one of the other nurses came up to her and was like, is that your student that works in peds?" And she was like, "Yeah." And she's like, they had a pediatric patient. The baby came in. She was 6 months old, had a fever, which like was pretty high for a 6 month old. And the doctor wanted a urine on her, and none of the nurses there had peds experience, and they were all nervous and they had to get a cath. And so because she, like I said, didn't know my name, she literally called me student, but she had already talked to everybody about me. And so they were like, "Could you come do a cath on this peds patient for us?" And I was like, "Sure," because I did caths all the time on babies. So I went in there and I got to show them how to do a cath on a peds patient because none of them have ever done it. Right. So that was my best experience in nursing school. And not all of them were like that. Um, and it was funny because she remembered me. We was in Walmart one night, and I hear, "Hey, student." And I'm like, "You've got to be kidding me." And I turned around and there she was. She was like, "How are you doing?" And I'm like, "Are you ever going to remember my name?" She goes, "Probably not." She goes, "But I'll always remember your face." And I just thought that was really interesting. So you're going to have good, you're going to have bad, but you ultimately get to choose the type of nurse that you want to be. And I'm going to leave it at that. Not everybody loves, like I said, not everybody loves to teach. If you had asked me when I was in nursing school if I ever thought I would be sitting here teaching nursing students, I would have laughed. I would have been, there is no way. I'm not a good teacher. There's no way. I'd probably mess everybody up. Like, I really felt like there was no way I could have ever been a teacher. And when I did get my master's degree and I did apply, I was like, okay, I'll do clinical. Like that was my thing. Like I can teach skills and I can teach that kind of thing. And then they dragged me into the classroom one term and I was like, okay, well, maybe this isn't that. And I'm going to tell you, there were struggles the whole, like that first year teaching. There was lots of struggles, but I don't know. Not everybody loves it. I do personally. I think it's amazing. It's awesome. I like teaching, and then of course I still work in the field, so I get the best of both worlds. But like I said, you get to choose what you want to do with your career and how you want to be and what kind of nurse that you want to be. And it's not just the nurse to your coworkers, right? It's the nurse to your patients as well, and the facility that you're working at. And only you can decide, what you want to do with that. And I will leave it at that. Does anybody have any questions? All right, guys. You guys have an amazing week, and I will see you next Monday. Take care.